a pro-con session regarding early intubation versus trial of NIV, an unsettled issue of critical care regarding intubation, and we will listen to the doyens of critical care, Anirban Home Chowdhury versus Sivakumar MN, and let us conclude the consensus whether to intubate or a trial of NIV. Mic is yours.
Very good morning, sir. At the very onset, I wish to thank my good friend Pradeep and his entire team for this wonderful hospitality and for inviting me for this debate. While I was coming through the debate, I was trying to think again the topic. Last night, someone told me, during the faculty dinner, see, if you drink, you become high. You get high. If you read, you get educated. But if you drink and read, you get highly educated. And that is not true. But if that is true, then today's debate is also true. Because at the end of the debate, when everyone was removing all the sweeper was cleaning all the stuff, he was also saying, blessed are the constipated, they don't give a shit. So I will start my talk on the subject, early intubation has no alternative in acute hypoxemic failure. Can I see my slides? I can start it with that why there is no other alternative than early intubation in acute hypoxemic respiratory failure. So we have a lot of things in our armamentarium. And sometimes we think that this is probably the most powerful weapon, or he is the most powerful person, or he is the least important person. So similarly, some time back, people were saying that Shushmita Sen, that you are very powerful. Why? Well, then no CBI, no ED, nobody could catch Lalit Modi, but you have caught him. So that way, the conception of which instrument has to be used when, that is a changing thing. It varies from time to time, situation to situation, and context to context. So, see, whenever we know that our patient is of hypoxemic respiratory failure, rather than not on hypercapnic respiratory failure, we know very well that these patients have a rapid downhill course. They develop organ dysfunction, and our main objective in such patients is to do anything to prevent mortality. Because unless and until we do intervene timely, these patients are much more likely to die than patients with hypercapnic failure. So whenever we do it, our basic management is to do everything to maintain the ventilatory management, hemodynamic stability, etc. And of course, after gaining that, to treat the primary cause. In this regard, honorable jury, you will realize that timing of intubation has a major, critical, and indisputable role in saving the life of the patient. If you see this study, you will realize very clearly, this was a wonderfully performed study, that patients in the late intubation subgroup had significant increased mortality at 60 days compared to the others. And this difference in mortality across intubation groups persisted at 60 days and at 1 year and 2 years of follow-up also. So you remember that single act of intubating or not intubating timely in a patient can create such a big difference that is beyond our thought. So this survival of patients in ARDS, timing of intubation is so crucial, we don't have to think or to argue about. You can again see that this is a very famous, the secondary analysis of the ICON audit. And I'm not going to repeat, because they have also found that in patients requiring intubation of greater than 2 days after admission, that means if after this number of days becomes more than 2, they have an increased mortality. But they have also found that these patients have a cumulative survival probability becomes higher because of a reduction in the hospital length of stay and in the ICU length of stay. So crucial is timely intubation in these patients. And it is also seen that the hazard of ICU and hospital death was significantly greater than 10 days after ICU. So there is no doubt, my jury, that the importance of timely intubation cannot be underestimated. If you see into this, we know that in sepsis, a lot of patients go into respiratory failure. And even in that, it is said that unless timely intubation has to be done, and in order to do, it is a settled fact that in order to timely intubation, patient factors, clinician factors, system factors must all be assessed for timely intubation. Otherwise, we will not be able to give a good outcome of the patient. If we see that during the COVID times, we have seen that the same thing has been observed in COVID also, even to the extent that the odds were 3.25. They were most likely to die if not well intubated in time. And very late intubation in these patients is that they try to see how long they can delay it after starting steroids. There also it is seen that if you delay intubation, then you are more likely to have a grim prognosis and the mortality rate can go up to 87%. Now, my respected jury, you will hear that all these things you are talking, I am talking about intubation. Now I am talking a few slides on NIV. So this is the lung safe study, you are all aware, such a large study in which it has been clearly demonstrated that NIV failure is strongly related with severity. More severe the ARDS, more likely the NIV will fail. And ICU mortality was higher with NIV in comparison to mechanical ventilation. If you see this large observational cohort study, they have observed a high failure rate in initial NIV therapy in medical critically ill patients. So if a large component chunk of our patients are medically critically ill, and in these patients, unless the underlying shock, metabolic acidosis, and severe hypoxemia are readily resolved, a trial of NIV is unlikely to be successful. Given the higher than expected mortality, it should be instituted with extreme caution. Therefore, whenever we are always talk of lung protective ventilation. And you remember that not only this study, but many studies have found that when we give NIV, we are not able to protect the lungs because it is not able to control the tidal volume to 6 ml per kg. We always tend to overshoot. So delivering lung protective ventilation is almost impossible during NIV. We also see that we have come up with this concept of SILI during the COVID times, but SILI existed much before also, that whenever we start NIV, we have to monitor these patients. Hacker score is one, because the choice, timing, and setting of NIV should be carefully tailored, otherwise there are complications. Respected jury, you please tell me in India how many ICUs are there where such a careful monitoring of these patients are practiced when the patients are NIV. The patient is put on NIV, everyone vanishes, and the patient ultimately loses the battle. Therefore, despite the strong rationale and huge volume of the data, the clear recipe that a team should use in the clinical is lacking. And results of randomized controlled trials by selected centers cannot be translated into a real-world scenario where skill standardization expertise is not always adequate. So this recipe has to be defined. Therefore, respected jury, this NIV has not found any place in this algorithm where in the practice of NIV, which has been come in 2019, published in the Annals of Intensive Care. Whenever we realize the importance, sometimes we realize when it is too late. So the importance of the rear seat belt is also realized sometimes a bit when time is gone. But we should keep in our hand that our power to ability to control the airway should not be, and we should be ready so that we don't lose time and hope. So the importance of early intubation should not be the same fate as the previous slide. So I pray to the God to give blessings. I can understand that by the grace of God, give wisdom to my opponent who is coming to speak on favor of NIV, but still in favor of NIV, that there is a long way to go. Thank you very much.
Good morning. Greetings from Coimbatore and my institution, Royal Care Super Specialty Hospital. Let me start by acknowledging my teachers who taught me anesthesia and critical care medicine. Like many of you here, I would also give a trial of NIV before I intubate these patients in acute hypoxemic respiratory failure. To the Honorable Chairperson and Dr. Anirban, I would like to mention it is a trial of NIV. So Anirban is a good friend and he's a great speaker. I think he gets very excited whenever he is in Bangalore. I think he gets very excited and he talks till midnight. And today he is here for a wrong cause. I want the chairpersons to note is so good speaker. Sometimes he can give wrong facts and he can convince people. So when Pradeep has given this academic commitment, I thought it is a gross mismatch. Somehow, because I was on the right side, I gathered confidence. Not always the favorites win. Sometimes there are surprises, and today is my day. As we all know, we don't have a strong data with regard to usage of non-invasive ventilation as we have in cardiogenic pulmonary edema or COPD exacerbation. But in the last 2 decades, we have seen that non-invasive ventilation is being used in more and more indication, particularly during the pandemic, and the benefits of non-invasive ventilation are being increasingly recognized. If you carefully select your patients in acute hypoxemic respiratory failure, you monitor them closely, this can be practiced very safely. Let me explain it to you. Is there a rationale to use non-invasive ventilation in patients with acute hypoxemic respiratory failure? Yes, there is a strong rationale. So, if you use a non-invasive ventilation in patients with acute hypoxemic respiratory failure, there is an alveolar recruitment which is happening. It increases your functional residual capacity, it decreases your VQ mismatch, it improves your hypoxemia. And it unloads your respiratory muscle, thereby it decreases your workout breathing. These two are strong physiological rationale to use non-invasive ventilation in patients with acute hypoxemic respiratory. More than that, I think the main benefit I would see in its usage is it avoids intubation and the complication related to mechanical ventilation. I think this is very, very important in a country like India where we see all the complications related to invasive ventilation. So what is the practice? So we know that there is a physiological rationale. What is the practice? Let me take it to your case. This is a middle-aged gentleman with comorbidities, presents with the short duration of febrile illness. He is hypoxemic. He has normal cardiac function. His PF ratio is 200. So what is the kind of respiratory support you would like to provide? Can I ask the delegates over here, do you want to intubate this patient straight away or you want to give a trial of NIV? Can you raise your hands if you want to give a trial of NIV? I think everyone would like to give a trial of NIV. I think even Anirban would give a trial of NIV in such patients. So if you look at the advantages with regard to usage of NIV in patients with acute hypoxemic respiratory failure, there are too many. I would not go into details for the want of time. And if you look at limitations, as Anirban rightly pointed out, the reduction in workout breathing is not very well proven as you have seen in patients with COPD. But when these patients are put on non-invasive ventilation, the inspiratory drive is more, they tend to fast breather. So with regard to it, there is an excessive tidal volume generated and there is an increase in transpulmonary pressure which could increase your ventilation associated lung injury, which you should be very cautious. So what is the major concern? Why we are so much worried whenever we want to start an NIV for a patient with acute hypoxemic respiratory failure? There is a high failure rate. The rate could be as high as 60%. This is more in ARDS patient compared to a non-ARDS population. And the mortality in these patients who are subsequently intubated after an NIV failure, the rates could be as high as 60. This is not entirely related to NIV failure, but probably this could be related to your severity of illness. And there are very good papers which clearly pointed out there is not much of difference with regard to mortality when you give a trial of NIV or you intubate them after a trial of NIV. I think the intubation related mortality is probably related to the severity of illness. And there are some papers which document that rather than directly intubating this patient, you give a trial of NIV and you intubate them after 12 hours, the mortality is higher. I don't know where they get this, but the message is, so if you delay the intubation, the patients are not doing well, you delay the intubation after an NIV trial, probably this is going to be associated with more mortality. This is a heterogeneous population. There is no strong data as of now, but other limitation would be to have a trained manpower, as my opponent pointed out, to monitor these patients when they are on NIV. And the high pressures it generates and the higher tidal volume it generates, these are the concerns whenever you use an NIV in patients with acute hypoxemic respiratory failure. But despite these concerns, the epidemiological data says that it is one of the main mode of support in patients with acute hypoxemic respiratory failure, even in subset of ARDS. So you're using a therapy which does not have a strong evidence, but this could be potentially beneficial. So you could be very cautious and you should look for failure early and switch over to invasive ventilation whenever possible. So what are the predictors of NIV failure when you're using this in a patient with acute hypoxemic respiratory failure? So these are well-validated risk factors, like when you have a PF ratio which is less than 150, when the severity of illness scorings are high, when the tidal volume is more than 9 ml per kg, when the underlying etiology is either pneumonia or ARDS, or the HACR score is more than 5. So these factors are very well validated. So whenever you put these patients on NIV, you look for these factors, and these are predictors of failure. When you have that, you switch them over timely to invasive ventilation. So this is the HACR score, which are well validated in different group of patients, and this has got 5 variables and score assigned to it. So you do it when you initiate NIV, and you do it after an hour, and this score is more than 5, probably you should switch over them at the earliest. So before I finish, this is the popular Frolari trial, which looks at the usage of high-flow nasal cannula, standard oxygen therapy, NIV in patients with hypoxemic respiratory failure. Though the intubation rates are not different between these three groups, but the mortality at 90 days is much lower with regard to usage of high-flow nasal cannula. And there is a lot of enthusiasm, particularly during the pandemic, with regard to the usage of helmet mask. So there are a lot of inherent advantages with related to usage of helmet mask. The main advantage being the patient tolerates it well, so you can have a longer sessions with helmet mask, and you can achieve higher pressures, so the success is much, much better. So these are the societal guidelines, and the ISCCM guidelines gives probably a level 2 recommendation for patients with acute hypoxemic respiratory failure. These are guidelines from European Respiratory Society and American Thoracic Society, which do not give any recommendations for patients with de novo respiratory failure. To conclude, we do understand these patients with acute hypoxemic respiratory failure are heterogeneous, and to have a strong data with regard to NIV usage is a bit difficult, and you may not get it. But if you could carefully select your patients and you monitor them closely and appropriately switch over to invasive ventilation, probably NIV can be utilized safely. And in an Indian context where you have a high hospital-acquired infection with regard to invasive ventilation, I think the benefit of NIV outweighs the risk of it. Thank you.
Okay, thank you very much. We'll take questions in the end.
No, it is time for rebuttal, I guess.
Okay.
2 minutes left for each one of us. So, very clearly, very intelligently, Dr. Sivakumar has said that ultimately, you can use NIV and be successful with lots of ifs and buts. Therefore, it is very clear as that bus station is a station where the bus stops, railway station is a station where the train stops, but workstation is not something where work stops. So therefore, it is very clear that this NIV can only work with lots of ifs and buts, unlike intubation, which is very precious act, which can save life, millions, and leave its long footprint. Someone once also said that if you have a poor father, it is your fate, you can't do anything. But if you have a poor father-in-law, that is a stupidity. Thank you very much.
It's an editorial which looked at alternative to invasive ventilation during the time of pandemic. This clearly discusses the advantages of various modes of non-invasive ventilation and various advantages. And so continuing with our patient, I think everyone agreed you will give a trial of NIV, and Dr. Anirban wanted to intubate this patient. And 5 days after ventilation, there is a new onset of fever, there is a purulent secretion, there is a hypoxemia, and he said ET culture, and he put them on empirical antibiotic. I think this is the culture he gets at GP Pant. I think it's a pan-resistant bug. So I think the evidence is not very strong and very robust, but considering the complications of intubation and mechanical ventilation, you should carefully select your patients. you should give a trial of NIV, look for risk factors for failure. Whenever they fail, make a timely switch over to invasive ventilation. Thank you.